Welcome back to the deep dive. Today, we are putting away the generalized anatomy textbooks, maybe pushing them aside a bit and pulling out the high-resolution MR images.
Good plan.
Because our mission today, really, is to stop practicing based on assumptions, and start operating with pinpoint surgical precision. We're diving past the familiar stuff, the standard ACL and MCL injuries that, frankly, we see all the time.
Yeah, the bread and butter.
Exactly. We want to focus on the deep anatomy, the stuff that truly dictates long-term surgical success. These are the intricate structures that, well, if you miss them in your initial workup, or maybe you fail to address them during the repair, you're basically guaranteeing the failure of an otherwise perfect reconstruction.
That's absolutely right. And look, for any seasoned surgeon, you learn this pretty early on, sometimes the hard way. Complex knee stability, it's really a game of millimeters.
Yeah.
And the difference between a stable, functional knee and, a symptomatic failure often resides in these areas that are traditionally hardest to see or maybe just harder to fully understand. So today, we are tackling those two critical yet often neglected poles of the knee. We're going from the subtle, multi-layered stability system in the back, the posteromedial corner, or PMC, to the massive high-load power generator right there in the front. The entire extensor mechanism.
I have to admit, as a resident, PMC always felt like the most punishing section of the anatomy textbook. It's just messy, isn't it? It's layered, functionally intertwined, and honestly, pretty confusing to visualize even on dissection.
It is complex, no doubt.
But your sources, particularly the clinical outcome studies you referenced here, they make it abundantly clear. Confusing or not, ignoring this region, especially when you're dealing with a multiligamentous injury. Well, it sounds like it's almost clinical malpractice.
It borders on it, certainly in terms of outcome. The clinical gravity of the PMC, it just cannot be overstated.
Yeah.
And what's truly remarkable, and frankly a bit frustrating as a clinician, is that the PMC anatomy is easily seen on modern high-field MR imaging systems. We have the tools.
We can see it.
We can see it quite clearly. Yet we still see it chronically unnoticed or perhaps unappreciated by many clinicians doing the initial reads or surgical planning. We absolutely have to treat this area with the same suspicion and respect we give the posterolateral corner in complex knee injuries.
Okay, same level of scrutiny.
Exactly. Why? Because an overlooked PMC injury, especially when it's combined with, say, an ACL or PCL reconstruction, it's not just a complication. It is a documented, predictable cause of early surgical failure and, critically, graft overload. The graft just won't last.
So our goal today really is to gain that appropriate granular understanding. We need to internalize the complex three-dimensional anatomy, understand its normal appearance on MR imaging, and maybe more importantly, what it looks like when it's injured.
Yes, the abnormal appearance is key.
And grasp the specific biomechanical function, What actually determines whether a knee stays stable or, under rotational stress, it just blows out.
All right, so our roadmap is, it's pretty dense today, but we'll move methodically. We're going to be breaking down the three distinct surgical layers of the PMC. We'll meticulously trace the five tendinous arms of its dynamic core, the semimembranosus.
The 5 arms, okay.
Then we're moving into the diagnostic challenge zone. Learning to identify crucial pitfalls like the notorious magic angle artifact that can mimic a tear.
Oh yeah, I've seen that trip people up.
It does. And we'll also look at the definitive signs of acute trauma, like the dreaded sliver sign you might see in the extensor mechanism after a dislocation.
Okay, let's unpack the security system then, the PMC, starting with the geography. When we talk about the posteromedial corner, what are its precise operative boundaries? Where does it start and stop?
Okay. Geographically, think of the PMC as the region situated between the posterior margin of the superficial medial collateral ligament specifically, the longitudinal fibers of the SMCL, and the medial border of the posterior cruciate ligament, the PCL. Now, you will see, as you mentioned, a mild degree of controversy in the surgical literature about exactly what to include. Particularly whether the posterior oblique ligament, the POL, should be lumped entirely in with the MCL complex or treated as its own distinct entity within the PMC.
Okay, bit of academic debate there.
A little bit, but for our purposes, functionally, the consensus is clear. This area, the PMC, is functionally indispensable. It is absolutely responsible for stabilizing that medial corner and, critically, restricting excessive anterior translation and external rotation of the medial tibial plateau relative to the femur. It's the key rotational stabilizer back there.
Got it. I think the layered architecture, that's probably the easiest way for residents like me to really conceptualize its complexity, maybe plan an operative approach. Can you walk us through those three distinct structural layers? I know they're referenced beautifully in figures 11.1 and 11.2 in the source material.
Absolutely. And thinking in layers is really the only way to approach it surgically, especially in a subacute setting where hopefully some of the landmarks are preserved. You need to know these layers cold because their integrity, layer by layer, dictates the repair strategy you're going to choose.
Makes sense.
Yeah.
Okay, starting superficially, we have layer 1. This is primarily the superficial fascia, the crural fascia, but crucially, it includes the terminal insertions of the pes and serine tendons.
Right.
That's the sartorius, the gracilis, and the semitendinosus. These muscles provide, dynamic protection and active support, but they aren't the primary static stability, are they?
No, they're dynamic, guys. Important, but dynamic. So when you dissect down through that fascia, you reach layer 2. Now, this is the first major static stabilizing component.
Okay.
It contains the superficial MCL, the SMCL, which is the primary static restraint to valgus stress, that opening up stress on the medial side across the knee at all angles of flexion.
The main medial ligament.
The main one, yes.
Right.
Layer 2 also includes the oblique popliteal ligament, or OPL, which we'll discuss more later.
Got it. And finally, the deepest stability complex, layer 3. This sounds like the real workhorse, where static and dynamic interaction happens.
It absolutely is. Layer 3 includes the deep MCL, which provides secondary static stabilization and is really inseparable from the joint capsule itself.
Right on the joint.
Right on the joint. The capsule itself is part of layer 3, and then the core dynamic stabilizer, the semimembranous tendon complex, resides here, too.
Okay, so if we use that structural armor analogy you mentioned, layer 1 is kind of the padded surface, the superficial stuff. Layer 2, with the SMCL, is like the thick outer plate, right, providing that primary resistance to getting pushed open medially.
Exactly, your main shield.
And then layer 3 is this complex inner lining, the deep MCL and the capsule providing stability right on the joint line, with the semimembranosus acting like an intricate system of internal ropes and pulleys, maybe.
That structural analogy holds up very well clinically, I find, because in acute trauma, distinguishing between, say, a grade 3 tear that only involves layer 2 versus a concomitant injury that rips through into layer 3, well, that's often the difference between potentially managing with a brace versus needing surgical stabilization. It dictates treatment.
Huge difference in management. Okay. Now, drilling down into the substance of the PMC itself, the components, we consistently describe 5 major components required for that true multi-layered stability. We've already mentioned the 2 ligaments, MCL, POL, and the muscle complex, SMT, but what else rounds out this vital quintet?
Right. The core 5 that you absolutely need to know are
the semimembranosus tendon complex, SMT. That's the dynamic core we keep mentioning.
Okay.
Number 2, the oblique popliteal ligament, OPL. Number 3, the posterior oblique ligament,
POL.
Number 4, the posteromedial joint capsule itself, part of layer 3.
Okay.
And number 5, critically, the posterior horn of the medial meniscus. Specifically, it's the meniscotibial ligament complex, which anchors that posterior horn firmly down onto the tibia. This last one is absolutely vital for that break-stop mechanism we need to dedicate some significant time to later. It's a huge player in long-term joint health.
The meniscal anchor. Got it. That makes 5.
Okay, let's focus intensely now on the SMT, the semimembranosus tendon complex. If the POL and the MCL are, let's say, the static steel cables providing passive restraint,
Yeah.
the semimembranosus is the single most important dynamic stabilizer of the PMC. It originates way up proximally at the posterolateral aspect of the ischial tuberosity, your SIPO. But, as you noted, the real complexity and the area we absolutely must master for surgical planning happens way down to distally as it inserts.
Exactly. It doesn't just insert like one big simple tendon. It splays out, right, into 5 distinct tendinous branches. It's like a hand spreading out.
Precisely. And that complex insertion allows it to exert multi-vector dynamic control across the entire medial corner of the knee. So when we're looking at axial and sagittal MR images, we have to be able to meticulously trace every single one of these branches to see if it's intact or injured.
5 separate jobs, potentially.
Essentially, yes.
Okay.
So let's run through those 5 anatomically distinct arms. This is crucial knowledge, the kind that really separates the general practitioner from the knee specialist.
Okay, let's do it. Arm number 1.
Number 1 is the direct arm. This is its principal attachment, its main anchor point. It courses deep to the other, more anterior attachments and inserts firmly at a very specific landmark, the tuberculum tendinus on the posteromedial tibial condyle.
Tuberculum tendinus, okay.
Now, clinically, what makes this arm so fascinating is its intimate relationship with the meniscus. Immediately prior to its final tibial insertion, it actually attaches to the coronary ligament of the posterior horn of the medial meniscus.
Ah, so that's the direct link, that strong connection to the meniscus's peripheral anchor. That must be what gives it that dynamic protective effect you mentioned earlier.
That's exactly it. It actively pulls on the meniscus during flexion. And you also mentioned something key earlier. While the direct arm tendon itself is quite strong, the bone at the tuberculum tendinus where it attaches often isn't as strong.
Right. The weak link can be the bone.
That's key. In high-energy trauma, especially involving forced abduction and external rotation, think of a skiing injury. We often see avulsion fractures right here, a bone failure, rather than a mid-substance tear of the tendon itself. The bone attachment site basically gives up before the tendon fibers do.
And you'd see that avulsion best on sagittal and axial images, right? Like a little chip pulled off with a low signal line.
Exactly. You trace the low signal fracture line, and you'll almost always see significant bone marrow edema around it, reflecting the impact.
Got it. Okay, moving to number 2, the anterior arm. This one is often called the tibial or reflected arm, or sometimes the pars reflexa. This one sounds like it's notorious for being a diagnostic trap.
It is. It has caught many people out. It extends anteriorly from the main tendon, passes under the posterior oblique ligament, POL, and then inserts on the medial aspect of the proximal tibia deep to the tibial collateral ligament, the MCL.
Okay, so it dives deep.
It dives deep and curves anteriorly. On medial peripheral sagittal images, it presents as this low signal structure, curving almost horizontally forward.
And that curved horizontal course, that brings us directly to our first major imaging pitfall you warned us about, the one that's led to countless unnecessary scopes and misdiagnoses. The magic angle artifact.
The magic angle artifact, yes. Referencing figure 11.10 in the materials for those following along. For the listener, this is where the pure physics of MRI completely mimics pathology. It looks like a tear, but it isn't necessarily.
Okay, how does it actually happen? And more importantly, how do we confidently distinguish it from a real tear on the scan?
Right, this is absolutely critical for anyone reading knee MRIs. The phenomenon occurs when the fibers of a structure, in this case, the collagen fibers within the anterior arm of the SMT, are oriented at a very specific angle, approximately 55 degrees, relative to the main magnetic field of the scanner, B0.
55 degrees, okay.
When you acquire images using a sequence with a short echo time specifically, a TE of around 20 milliseconds is classic for this specific angulation causes an inherent focal area of high signal intensity within the tendon or ligament. It looks bright.
Right. So a less experienced eye sees that bright signal, that whiteness on a T1 or PD sequence, and immediately calls it tendinopathy or maybe even a partial tear.
Exactly. Because high signal usually means fluid or degeneration.
Yeah.
But here it's potentially just an artifact of the imaging geometry, not necessarily a true injury. So the differential diagnosis becomes absolutely critical. Is this high signal intensity real pathology, or is it just artifact?
How do you make the call?
You distinguish them by recognizing that specific signal intensity in that specific location, the known path of the anterior SMT arm, and by knowing the sequence parameters, particularly that short TE. If you suspect it's artifact, you have a couple of options. You can switch to a sequence with a long TE, like a T2 sequence. The artifact usually disappears on long TE sequences.
Okay, change the sequence.
Or you look carefully for secondary signs of a true injury. Does the tendon look irregular or thickened? Is there surrounding edema or fluid? Is there a clinical correlation? Does the patient have tenderness right there? True tendinosis, like in figure 11.18, will usually show some surrounding inflammation, maybe some fraying or irregularity of the tendon fibers. The magic angle artifact, on the other hand, is often smooth, focal, and confined just to that expected region of the tendon without those secondary signs.
Got it. It's like a mirage in the knee, as you said. If you can't trust the signal based on the physics, you can't trust the diagnosis. You have to know about the artifact.
You absolutely have to know about it. Okay, now for the rest of the SMT crew. Number 3, the capsular arm. This is a deep-lying structure, quite flat, often described as striated. It combines intimately with the posteromedial capsule itself, and it joins the capsular portions of the OPL and the POL. It sort of blends everything together back there.
Sounds hard to see distinctly.
It often is elusive on standard scans. But, as referenced in figure 11.9, it becomes much easier to visualize as a separate structure if the joint is distended by fluid, like if there's a large effusion. The fluid outlines it better.
Okay, fluid helps. Makes sense. Number 4 is the OPL extension. This sounds straightforward. It just feeds into the broader oblique popliteal ligament complex.
Correct. It's essentially the contribution from the SMT to the OPL structure. And finally, number 5, the inferior, or sometimes called the popliteal arm.
The inferior arm. Where does this one go?
This arm extends more distally, inferiorly. It passes under the distal tibial segments of the POL and also the tibial collateral ligament, MCL. It inserts just above the tibial attachment of the TCL itself. On axial views, you typically see it as a low-signal structure extending inferiorly and slightly anteriorly deep to the MCL.
Wow. The sheer complexity of these 5 arms, it really demonstrates why the semimembranosus is often likened to like the complex wigging on an old sailing ship, right? You've got these 5 specific cables all pulling in slightly different directions to provide really fine-tuned stability throughout the knee's full range of motion.
That's an excellent analogy. It captures the multivectorial nature of its dynamic function perfectly.
Okay. That makes the connection explicit. Now let's discuss those other cables. You mentioned the scatic ones. Starting with the posterior oblique ligament, the POL, sometimes called the ligament of Winslow.
Right. The POL is arguably the central coordinator of the PMC static structures. It originates fairly high up on the femur at the adductor tubercle. Now, its anterior margin combines pretty seamlessly with the posterior margin of the superficial MCL, so they look almost continuous there.
Okay.
And its posterior margin blends directly into the joint capsule layer 3. Conceptually, I think of the POL as the central control cable that coordinates the tension between the medial collateral ligament, SMCL, out more superficially, and the posterior capsule deeper in. It ensures they work together effectively to resist rotational forces, particularly external rotation.
And it's not just one solid band, is it? The sources say it has 3 inseparable bundles or arms of attachment. The superficial arm, the capsular arm, and then the thickest, most functionally important part, the tibial arm.
Yes, the tibial arm is absolutely key. It extends posteriorly and obliquely downward, inserting into the posteromedial aspect of the medial meniscus itself and also onto the adjacent tibia right behind the meniscus. This is the bundle that actually migrates deep to that anterior arm of the semimembranosus we just discussed.
Ah, so they cross paths.
They do. And the POL's tibial arm finally merges with the main SMT tendon insertion. This intricate dynamic connection is precisely why you cannot functionally or surgically separate the SMT from the POL. If one fails, the other is immediately put under significantly more stress and is likely compromised as well. They are truly linked.
Okay, inseparable partners. And rounding out the stability trio is the oblique popliteal ligament, the OPL. This is described as a thin, broad, lateral extension of the semimembranosus tendon itself.
That's right. It acts as an important broad band reinforcement, covering and blending with the posterior medial capsule. Interestingly, it extends quite far laterally, often beyond the midline of the joint posteriorly, to unite with the arcuate ligament complex coming from the posterolateral aspect of the knee.
So it kind of bridges across the back.
It does, forming a sort of posterior sling. Functionally, the OPL plays a key specific role in preventing genu recurvatum, which is hyperextension of the knee. So if you have a patient presenting with knee hyperextension instability after an injury, you have to suspect posterior capsular injury and very likely OPL involvement, because that's your primary check against the knee bending backwards too far.
Got it. OPL equals hyperextension block. Okay, we've established the anatomy, the players involved. Now let's really talk function and, crucially, the failure modes. We have the static structures, those passive restraints like the POL, the MCL, the capsule, and then the dynamic structures, the active support from the SMT and the pes anserinus muscles.
Right. And the biomechanics of the PMC are beautifully orchestrated by the position of the knee. Take the POL, for example. It's naturally relatively relaxed when the knee is in flexion, which allows the knee to bend freely without restriction.
Makes sense.
But as the knee moves toward full extension, and critically, as the tibia externally rotates slightly during that terminal extension phase of the screw-home mechanism, the POL rapidly becomes caught. It tightens up, and this tightening pulls all those PMC components together.
Like cinching a drawstring bag.
Exactly like that. It creates this crucial protective pouch around the back of the medial femoral condyle, essentially locking the stability in place when you are weight-bearing in full extension. It provides that final rotational stability.
And the SMT, the semimembranosus, is the star of the dynamic show, you said. We know its primary action when the muscle contracts is flexing the knee and internally rotating the tibia.
Correct.
When the knee is extended, its contraction can actively help prevent valgus motion, and when the knee is flexed, it helps prevent excessive external rotation. But you mentioned its most critical long-term protective role focuses specifically on that posterior horn of the medial meniscus.
Yes, this is a major insight, I think, and one that really determines long-term joint health. particularly avoiding arthritis. The SMT provides active traction, it pulls, on the posterior horn of the medial meniscus. It dynamically prevents that posterior horn from being compressed or trapped between the femur and the tibia, especially during deep knee flexion.
So the SMT is basically pulling the meniscal horn safely out of the way before the joint closes down on it in deep flexion, like getting your finger out of a closing door.
That's a great way to visualize it. And because the SMT's line of pull is roughly parallel to the femur, its protective effect is actually greatest around 90 degrees of knee flexion. It becomes slightly less effective as the knee moves toward full extension.
Okay. And if the SMT fails to provide that protection, maybe because it's torn, or if those deeper attachments, particularly the meniscal one, are lost, then we get into what you termed the break-stop mechanism failure. This sounds like something we maybe don't focus on enough until the patient comes back years later with significant medial compartment arthritis symptoms.
Unfortunately, that's often true. And this is a concept that really needs to be, well, shouted from the rooftops, especially for surgeons treating acute knee injuries. The meniscotibial ligament complex, those fibers anchoring the posterior horn of the medial meniscus securely down to its tibial platform, provides this essential break-stop function.
Okay.
Its entire purpose, biomechanically, is to prevent posterior translation of the tibia relative to the meniscus during weight-bearing and high-load movements. It holds the meniscus stable on the tibia.
So if that meniscotibial ligament is insufficient or damaged, which sounds like a hallmark of a significant PMC injury, that essential break-stop mechanism is just gone.
Precisely. Without that reliable brake, the posterior medial meniscus basically becomes unstable on its tibial platform, and the downstream effect is, frankly, catastrophic for the joint long term. The meniscus and the femoral condyle above it start to move together abnormally. They slide excessively, posteriorly, over the tibial articular surface with every step, every squat. You lose the critical shock-absorbing function of the meniscus in that region, you lose its stabilizing contribution, and you dramatically increase the shear and compression stress on both the meniscus itself and the underlying tibial articular cartilage.
Leading to breakdown.
Exactly. This leads rapidly to accelerated wear and tear, specifically medial compartment arthritis, sometimes developing decades ahead of schedule compared to the uninjured side. It's like relying on a small car wheel chock to hold a semi-truck on a steep hill.
Yeah.
If that chock, the meniscotibial ligament, is gone or damaged, the whole assembly just rolls forward unexpectedly, damaging everything in its path. The cartilage gets ground down.
Wow. That analogy makes the long-term stakes terrifyingly clear. Okay, now let's review the load sharing quickly, because the PMC doesn't work in isolation, right?
Right.
It's an essential part of the larger restraint system for the whole knee.
Absolutely. The superficial MCL, the SMCL in layer 2, is and remains the workhorse against valgus stress. It's the primary restraint to medial opening at all angles of flexion.
Okay, SMCL is king for valgus.
But critically, when the knee is in full extension, the PMC structures, particularly the POL and the deep MCL in layer 3, step up significantly. They contribute about 1/3 of the total support required to restrict valgus stress in full extension. So they're very important when the knee is straight.
Got it. And the POL, you described it as the versatile multifunctional restraint.
It really is. It's an essential stabilizer against internal rotation of the tibia at all flexion angles. But here's the critical interaction. When the SMCL is sectioned or completely ruptured, like in a grade 3 tear, the POL steps up dramatically. It becomes a crucial secondary stabilizer for both valgus stress and external rotation. This is the core biomechanical reasoning behind why most surgeons believe a complete grade-through MCL tear often requires concomitant POL-PMC assessment and likely repair or reconstruction, because the injured MCL alone simply cannot handle the load once the POL is also compromised or if the POL was already injured.
Okay, that makes sense why you have to fix both if both are gone. And this leads directly to its role as a secondary stabilizer for cruciate injuries, which is what ties it directly to those surgical failures we talked about earlier. You mentioned the PMC provides secondary stabilization for anterior tibial translation in ACL-deficient knees.
Yes, specifically the POL contributes significantly to that check against anterior translation, particularly when rotational stress is involved. This is partly why you sometimes see athletes with a completely torn ACL who still exhibit remarkable functional stability, at least for a while.
The so-called Coopers.
Exactly, the Coopers. Their intact PMC and posterolateral corner structures are compensating, picking up the slack for the missing anterior restraint provided by the ACL. But that compensation comes at a cost. It puts enormous stress on those secondary structures, eventually leading to PMC failure if the ACL isn't reconstructed and the PMC isn't protected or addressed.
And conversely, the POL delivers secondary stabilization against posterior tibial translation in PCL-deficient knees, right? With its support increasing with internal rotation of the tibia.
That's correct. It acts as a secondary check to posterior jaw, especially in an internal rotation.
So when all these instabilities are combined, especially when you have failure of the MCL and the POL, that's when you get the really complex rotational failure pattern known as anterior medial rotational instability, or AMRI.
Precisely. AMRI is the clinical nightmare.
Okay, AMRI isn't just a simple anterior slide of the tibia, like in an isolated ACL tear. How do we precisely define this specific failure pattern? The one that's the absolute bane of the ACL reconstruction surgeon.
Okay, AMRI is defined by a combination of movements. It's external rotation of the tibia combined with anterior subluxation of the medial tibial plateau relative to the femur. And this happens simultaneously with excess opening of the medial compartment, which indicates the MCL failure. So it's an anterior translation, but specifically of the medial side, coupled with external rotation and medial opening. The rotation is the absolute key differentiating factor from a simple anterior jaw test.
I see. So the tibia is rotating out as it slides forward on the medial side in this specific rotational subluxation pattern. This is what potentiates severe stress on ACL and PCL grafts, delaying or preventing healing.
It does much more than just delay healing. In many cases, it almost guarantees eventual failure of the graft. The major takeaway, and this references the crucial outcome studies in sources 12, 27, and 29, is absolutely non-negotiable for anyone doing orthopedic surgery, especially knee ligament work.
Okay, what is it?
Patients who undergo ACL reconstruction, but who have overlooked pre-existing PMC injuries, specifically injuries that lead to AMRI, have a significantly increased risk of ACL graft failure, period.
Significantly increased.
Yes. If you fail to surgically correct the simultaneous PMC injury, you are setting up that brand new, expensive, hard-won ACL graft for dramatically increased rotational tension and mechanical overload. It's simply destined for early failure. You must fix the whole corner, address the AMRI, or the ACL reconstruction itself is compromised from day one.
So the failure isn't just, cosmetic laxity, it's truly structural. We're essentially asking the ACL graft to handle loads the intact knee never, ever intended it to handle alone.
Precisely. You've lost the crucial secondary static restraints, the OL deep MCL, and the dynamic restraints, SMT, that normally check that rotation. And now the poor ACL graft is suddenly being asked to be the sole restraint for both anterior translation and internal-external rotation control. That's a load profile it was simply not designed for, and it will eventually stretch out or rupture.
Okay. If AMRI and these underlying PMC injuries are such predictors of failure, we absolutely must be expert at spotting them on MRI. Let's look at the specific appearance of semimembranosus injuries first. We're referencing figures 11.14 through 11.18 here from the source materials.
Right. SMT injuries are actually very common in high-energy posteromedial trauma. You often see them occurring alongside ACL tears, MCL tears, and medial meniscus tears, the unhappy triad or variations thereof.
Makes sense. It's all connected back there.
Exactly. And the most frequent manifestation, as we discussed earlier with the direct arm, is the avulsion fracture, right at that tuberculum tendinus. Remember, the insertional tendon itself is often stronger than the bone it pulls from.
Right. So on MRI, an acute avulsion fracture like in figure 11.14, how does that look? You mentioned the low signal line.
You'll see that low signal fracture line right at the posteromedial tibial condyle where the direct arm attaches. And it's almost always associated with significant surrounding high signal bone marrow edema, or a bone bruise, on fluid-sensitive sequences. That edema reflects the high impact energy required to pull the bone off.
And seeing that avulsion, you said, means you have to assume the associated structures are also compromised, like the coronary ligament and the meniscus attachment.
Absolutely. Until proven otherwise on the MRI or clinically, that avulsion signals major trauma to that specific anchor point. Now, true mid-substance tendon tears of the SMT are less common than avulsions, but they certainly do occur. When they do, a complete tear, as shown in figure 11.16, is typically seen as a clear discontinuity of the tendon fibers, with high signal intensity hemorrhage and edema filling the gap between the retracted ends.
Okay, pretty straightforward for a complete tear. Now, for chronic injuries, maybe in athletes with chronic valgus stress or subtle instability, we shift our focus from acute tears or avulsions to tendinosis, right?
Correct. Chronic tendinosis, which is nicely demonstrated in figure 11.18, is typically visualized as increased intermediate signal intensity within the substance of the distal SMT insertion. It's not bright white like fluid, but sort of murky gray. This is usually accompanied by some irregularity of the tendon fibers, maybe some thickening, and often secondary cystic changes right at the bony insertion on the posteromedial tibia.
And the key here, again, is differentiating this chronic tendinosis from that pesky magic angle artifact we talked about.
Precisely. Magic angle is purely geometric signal change, usually smooth and focal, disappears on long TE sequences. True tendinosis shows signs of architectural failure, degeneration, maybe those cystic changes, and also persists across different sequences, though the signal might change intensity. Context and secondary signs are everything.
Got it. Okay. Moving to the ligaments. The POL and OPL injuries. The POL injury, according to the sources, sounds like it's the absolute key to symptomatic AMRI.
It really is. The clinical literature is strikingly definitive here. One major study that looked specifically at surgically repaired knees that had documented medial-sided injuries and symptomatic AMRI found that 99%, virtually all of them, had an associated POL injury identified at surgery.
Wow, 99%. That correlation is almost diagnostic in itself.
It's incredibly strong. So if you're seeing clinical signs of ARI on your exam, you should be actively hunting for POL failure on the imaging. It's almost certainly there.
Okay. And when grading these POL injuries on MRI, we just use the same scale as we use for MCL tears, right? Grades of first, 2, and 3.
Correct. The grading system is analogous. A grade OL tear is essentially a sprain you see surrounding edema, maybe some thickening, but the ligament fibers are intact, no discontinuity.
Okay.
A grade 2 tear, like in figure 11.19, is a partial thickness tear. You'll see partial discontinuity of the fibers, along with ligament thickening, surrounding edema, and maybe some hemorrhage signal.
Some fibers torn, some intact.
Exactly. And then a grade 3 tear, shown in figure 11.20, is the complete rupture. You see full ligament discontinuity, often with retraction of the torn ends, and usually significant surrounding edema and hemorrhage in the acute phase.
Got it. And what about OPL injuries? You mentioned they're harder to see directly.
They are. The OPL is thin and broad, blending with the capsule. So we often see OPL injuries implied rather than explicitly visualized as a torn ligament. They typically manifest as increased signal intensity, edema, and maybe thickening within the substance of the posterior joint capsule itself, indicating a general capsular failure in that region, which includes the OPL territory.
So capsular signal suggests OPL involvement. Okay. Now, let's pivot quickly to the physical exam. Clinically, how do we actually confirm this complex instability? You mentioned that PMC symptoms are usually nonspecific, especially acutely, due to high pain levels.
Right. The physical exam in the acute setting, maybe the first day or two after injury, is often quite unreliable because of patient guarding, swelling, and pain. And that's precisely why MRI becomes so indispensable for accurate diagnosis and pre-surgical planning in these complex injuries.
Makes sense. But if you can get a reliable exam maybe a few days later or under anesthesia, what's the key test to identify PMC failure specifically?
The key test is the abduction stress test, or valgus stress test.
Okay, and we perform that at both 0 degrees of flexion, so full extension, and at 30 degrees of flexion.
Correct.
What are the abnormal findings that point specifically to PMC involvement beyond just an isolated MCL tear?
This is critical. Normally, there should be no, or maybe just a tiny bit of medial joint space opening when you apply valgus stress at 0 degrees of flexion, full extension. The posterior capsular structures, primarily the POL and the deep MCL in layer 3, are maximally taut in full extension, essentially locking the joint medially.
Okay, should be solid at 0 degrees?
Should be solid. If you observe any significant opening, any laxity, when applying valgus stress at 0 degrees, that strongly implies that those primary static restraints in layer 3 are completely compromised. That is a very strong indicator of significant PMC injury going beyond just the SMCL.
Got it. And what about at 30 degrees?
At 30 degrees of flexion, the SMCL is the primary restraint. Now, an isolated grade 3 SMCL tear might allow, say, 10, 15 millimeters of opening. However, if you see dramatically increased laxity at 30 degrees, significantly more opening than you'd expect, or just an isolated MCL tear, that also suggests multiligamentous instability involving the PMC structures as well, the amount of opening is key.
Okay, so opening at 0 is bad, excessive opening at 30 is bad. And the specific test for AMRI itself, how do you elicit that rotational component on exam?
AMRI itself is defined on exam as eliciting a positive anterior drawer test, but specifically with the tibia held in external rotation. That rotational component is absolutely non-negotiable for the diagnosis of AMRI. You need to externally rotate the foot and tibia, then pull forward. If the medial plateau slides forward excessively in that position, that's AMRI.
Okay, drawer and external rotation. And if you suspect a combined PCL-PMC injury...
That is often demonstrated with a positive posterior drawer test performed with the tibia held in internal rotation.
Internal rotation for PCL-PMC. Why?
Because normally, internal rotation tightens some secondary restraints and should limit posterior drawer. But if the PMC, particularly the POL, is gone, that check against posterior sag in internal rotation is lost, demonstrating the combined instability pattern.
It sounds like the absolute key is that rotational component on exam don't just pull the tibia straight anteriorly or posteriorly. You have to try to reproduce the injury mechanism by adding rotation.
Exactly. You must test in rotation or you will miss the functional instability pattern, particularly AMRI.
Okay. Finally, the management decisions. Based on the exam and MRI findings, when do we immobilize and rehab, and when do we absolutely need to operate on these PMC injuries?
Okay, for a truly isolated PMC injury, which frankly is a rare occurrence, usually these happen with other ligament tears. But if it is truly isolated and maybe low grade, conservative management with bracing and focused physiotherapy can sometimes be the choice.
Right.
However, if the patient presents with symptomatic functional AMRI, whether that's isolated, again, rare, or much more commonly associated with an ACL or PCL injury, then surgical treatment is almost always mandatory for optimal long-term outcomes and to protect the cruciate graft.
Gotta fix the rotation. And the sources mention several surgical techniques: implication, advancement, augmentation, and reconstruction for the POL and CL complex. Can you briefly touch on those?
Sure. The choice really depends heavily on the chronicity and the extent of the tear, as well as the tissue quality. In acute injuries, maybe within the first few weeks, if the tissue looks good, you might attempt a primary repair, or perhaps application, where you essentially reattach the torn ligament ends or tighten up the stretched out tissue with sutures.
Okay, direct repair, possible.
If possible. For more chronic injuries or high-grade tears where the tissue is retracted or poor quality, you often need augmentation or full reconstruction. Augmentation might involve reinforcing a repair with suture tape or a small graft. Reconstruction typically involves using autografts, like hamstring tendons, or allografts, donor tissue, to completely rebuild the POL and sometimes the MCL complex.
Building a new ligament.
Essentially, yes. But the core principle remains absolute, regardless of technique. It is imperative to surgically correct simultaneous PMC injuries when performing cruciate ligament surgery. We already discussed the ACL graft failure risk. And remember, an overlooked PMC failure in the setting of a PCL injury leads to massive increases in posterior tibial translation, and, as we noted with the brake stop mechanism, rapidly accelerates medial compartment arthritis. We absolutely have to address the whole corner, stabilize the rotation, or the patient inevitably pays the price, maybe decades later, with pain and arthritis.
A crucial point. And quickly, what are the main complications a resident like me needs to be particularly aware of or counsel patients about after these complex posteromedial reconstructions?
Number one enemy postoperatively is stiffness, arthrofibrosis. These are significant reconstructions, often involving multiple ligaments in the capsule. Aggressive immobilization, or just the inflammatory response to surgery, can lead to profound loss of range of motion if rehab isn't managed carefully.
Stiffness.
The second, and perhaps more acute surgical complication, is saphenous nerve injury. The saphenous nerve and its infrapatellar branch run right through the surgical field during the medial approach required to access the deep layer 3 structures and the SMT complex. Careful dissection and nerve identification are paramount to avoid numbness or painful neuroma formation. Those are the big two to watch for.
Okay, we are shifting gears completely now, moving from the complex, multi-layered passive stabilizers of the posterior knee to the absolute powerhouse of the anterior knee, the extensor mechanism. This system is critical not just for, kicking a ball, but for everyday function like climbing stairs, standing up, and especially for deceleration.
Absolutely. And it's important to think of it not just as a collection of individual muscles and bones, but as a single integrated functional unit. The extensor mechanism is this tightly interconnected complex involving the quadriceps muscle group, the quadriceps tendon coming down, the patella acting as a fulcrum within that tendon, the patellar tendon continuing down, its insertion at the tibial tubercle, and crucially, the surrounding soft tissue envelope, the retinaculum, that helps guide the patella.
Right, and its function is primarily knee extension, obviously, but its role in dynamically stabilizing the patella, particularly against lateral forces trying to pull it outwards, is equally vital for normal function.
Precisely. Patellofemoral stability is a huge part of his job.
Now, from an imaging perspective, MRI is obviously ideal for evaluating this mechanism because of its superb soft tissue contrast. What's the optimal MRI protocol when you're specifically concerned about the extensor mechanism or patellofemoral issues?
Right. To really maximize resolution and be able to differentiate subtle tears, especially in the retinaculum or cartilage damage, we generally prefer closed high-field scanners 3 Tesla, if available, or at least a modern 1.5 Tesla system.
Need the signal.
Need the signal. And using a dedicated knee coil is absolutely non-negotiable. It maximizes the signal-to-noise ratio, SNR, giving us the sharp, high-resolution images necessary for detecting those fine retinacular tears or subtle conjugal defects.
Okay. And what's your go-to workhorse sequence for looking at the extensor mechanism, especially when you're interested in cartilage integrity and maybe tendon issues?
The proton density weighted PD sequence, it remains the absolute mainstay for general musculoskeletal imaging, and particularly for the knee. It provides excellent soft tissue contrast between different structures, gives very high spatial resolution, and is particularly sensitive to subtle cartilage abnormalities like fibrillation or partial thickness loss, and also early signs of tendinosis within the quads or patellar tendon.
PD is king.
PD is king for morphology. But we always supplement the PD sequences with fluid-sensitive sequences. That could be a CR sequence, or more commonly now, sequences with fat suppression like a T2 fat sat or a PD fat sat. Why? Because fluid enhancement, seeing the bright signal of edema or hemorrhage, is absolutely necessary to clearly delineate acute pathology. It enhances the conspicuity of tears, contusions, and inflammation.
Makes injuries pop out.
Exactly. And one more point. If we're dealing with a patient who has previous hardware in the knee, maybe from an earlier arthroplasty or an ORI of a patellar fracture.
Yeah, the metal artifact.
Exactly. Then you absolutely must use specialized metal artifact reduction techniques, often called MARS sequences, or similar proprietary names. Without these, the strong local magnetic susceptibility artifacts induced by the metal hardware will completely obscure the surrounding soft tissues, the tendons, the retinaculum. You won't be able to see if there's a joint effusion. MARS sequences are designed to minimize that artifact ballooning, allowing us to actually see the tissues immediately adjacent to the metal.
Critical for post-op or hardware patients. Okay, let's discuss the most common acute injury to this system. Traumatic lateral patellar dislocation, or LPD. Seems like we see this a lot, especially in younger athletes.
We do. LPD is frequently a non-contact injury, typically occurring during athletic activity involving cutting or pivoting. The classic mechanism is internal femoral rotation on a fixed tibia when the knee is partially flexed, maybe 20-30 degrees.
The valgus collapse position.
Exactly. This dynamic loading creates an overwhelming valgus and lateralizing force vector on the patella, causing the primary medial restraint, the medial patellar retinacular complex, to fail, and the patella pops out laterally over the edge of the trochlea.
And here is that crazy clinical paradox you mentioned earlier. LPD may be clinically unsuspected in a staggering 73% of cases reported in some studies.
Yes, and that's the absolute critical teaching point for any resident or ER physician seeing acute knee injuries. It's often missed on initial presentation. Why? Because spontaneous relocation of the patella back into the groove is very common. The patient might feel a pop, feel something go out and back in, but by the time they get to you, the patella might look grossly aligned. Add to that an acute, tense hemarthrosis filling the knee, making it incredibly painful to examine.
So you can't really test patellar tracking reliably?
Exactly. So if a patient comes in with a significantly swollen knee after a non-contact twisting injury and they felt a distinct pop or giving way, even if the knee looks grossly reduced, LPD absolutely must be at the very top of your differential diagnosis until proven otherwise by imaging.
Assume LPD until proven otherwise. This makes the characteristic imaging findings on MRI paramount. What are the key things we are looking for in LPD? We're referencing figures 12.2 and 12.3 here.
Okay, first, look at the soft tissue damage medially. Even if the patella has relocated, you will often see residual lateral patellar tilt, or maybe even frank lateral subluxation compared to the trochlea. Critically, look for the joint effusion, which is often a hemarthrosis blood in the joint appearing bright on T2-STIR.
Okay, Kilton blood.
Then the signature injury is the tear, or at least sprain, of the medial patellar retinacular complex. This includes the medial patellofemoral ligament, MPFL, which is the single most important static medial stabilizer, running from the medial patella to the adductor tubercle area on the femur.
The check crane ligament.
The main check crane, exactly. The tear often involves the adjacent vastus medialis obliquus VMO muscle fibers as well, as the VMO insertion blends with the MPFL superiorly. Figure 12.2 in the materials beautifully illustrates the edema, discontinuity, and hemorrhage you might see in this medial retinacular region after an LPD.
Got it. Tear the medial leash. And what about the bony consequences? Where do we look for bone bruises or fractures?
Right, we look for characteristic bone contusions or bruises. These occur in two fairly distinct patterns reflecting the mechanism. You can get a primary contusion where the medial facet of the patella impacts the lateral femoral condyle as it dislocates out.
Intact on the way out.
Or, perhaps more commonly, you see the secondary kissing contusion pattern. This happens when the patella impacts the lateral femoral condyle upon spontaneous relocation. The inferomedial patella kisses the anterolateral femoral condyle. These impacts can also cause shear forces.
Okay. And this brings us to the most specific high-yield sign for confirming a recent LPD, even if the soft tissue signs are subtle. The sliver sign.
The sliver sign, yes.
Define that for us. What is it exactly?
The sliver sign is simply the presence of a small, displaced osteochondral fragment, a piece of bone with its overlying cartilage, visualized floating freely within the joint, usually seen best within the joint effusion. Figure 12.3 shows an example.
A little chip floating in the fluid.
Exactly. That fragment is typically the result of the shear forces or impaction during the dislocation-relocation event. It's usually avulsed either from the medial patellar facet or sometimes from the lateral femoral condyle margin. Its presence is highly specific and strongly correlates with a recent LPD, even if the patella has already relocated perfectly and the medial soft tissues maybe aren't dramatically torn. Finding a sliver essentially means the patella failed recently and violently enough to knock off a piece of bone or cartilage.
So, see a sliver, think LPD. Okay. Beyond just diagnosing the acute injury, the long-term prognosis and the management plan for LPD depend heavily on identifying any underlying predisposing factors, right? We need to figure out why that patella dislocated in the first place, or else we just risk recurrence after recurrence. What are the key anatomic risk factors we need to assess on the imaging?
Absolutely critical question, because this is where surgical planning gets much more complex than just fixing the torn MPFL. We're primarily looking for three major structural or alignment risk factors on MRI or sometimes CT.
Okay, number one.
Number one is trochlear dysplasia. This refers to an abnormality in the shape of the groove on the femur, the trochlea, where the patella is supposed to track. Instead of having a nice, deep, stabilizing V shape, you might see a shallow groove, a flat surface, or in severe cases, even a convex, dome-shaped trochlea. This is often graded using the de Jure classification, with type D being the most severe flat or convex shape. If the patella essentially has no bony wall laterally to guide it, it's obviously much more likely to slip out over the edge. Assessing this accurately requires good axial imaging through the distal femur.
So flat track makes it easy to derail.
Okay.
Second risk factor, we look at patella alta.
Patella alta, exactly. This simply means a high-riding patella relative to the femur and trochlear grooves. If the patella sits too high proximally, it means it doesn't properly engage within the bony confines of the trochlear groove until the knee is flexed quite significantly.
So in early flexion?
In early flexion, say 0 to 30 degrees, where many non-contact injuries occur, the high-riding patella is essentially sitting up on the relatively flat proximal part of the femur, not protected down within the deeper part of the groove. It has less bony stability. We typically measure this using specific ratios on sagittal images, like the Insall-Salvati ratio or the Quetenon-Deschamps index. Certain values indicate pathologic patella alta.
Got it. High patella equals less engagement. And finally, the alignment factor. The relationship between the tibial tubercle, where the patellar tendon attaches, and the trochlear groove. This is measured as the TTTG distance.
Right, the tibial tubercle to trochlear groove, TTTG distance. This measurement, usually done on superimposed axial MRI or CT images, assesses the effective lateral pull vector on the entire extensor mechanism. A TTTG distance greater than about 15 millimeters and certainly greater than 20 millimeters is generally considered significantly pathological.
What does a high TTTG mean functionally?
It indicates that the patellar tendon insertion point on the tibia is too far lateral relative to the groove it needs to track in. This creates an excessive lateral pull on the patella every single time the quadriceps contracts, constantly predisposing the patella to drift or dislocate laterally under load. Surgery in these cases often involves an osteotomy cutting the bone to actually medialize the tibial tubercle, moving the insertion point medially to reduce that abnormal lateral pull vector.
Wow. Okay, so that shifts the whole discussion from just a simple soft tissue repair of the MPFL to potentially complex bony reconstruction and realignment surgery. What's the current general thinking on management pathways? When do you just repair the MPFL versus when do you need to do a full reconstruction, maybe with those bony procedures?
It's a spectrum, and somewhat controversial still, but generally.
Yeah.
For a first-time acute traumatic dislocation, especially in the younger patient, where the underlying bony alignment factors like trochlear dysplasia and TTTG are near normal or only mildly abnormal. Conservative management with bracing and rehab, or sometimes a primary repair of the acutely torn MPFL, is often attempted first. The idea is to let the native tissue heal.
Okay, try conservative or repair first if alignment is good.
But if the patient has recurrent dislocations, meaning it keeps popping out despite rehab, or if the underlying anatomy is severely abnormal from the start, like significant trochlear dysplasia, marked patella alta, or very high TTTG distance, then a formal MPFL reconstruction, usually using a hamstring autograft or sometimes an allograft to create a new ligamentous tether.
Rebuild the leash.
Rebuilt the leach, exactly. That reconstruction, often combined with a bony procedure to address the underlying alignment issue, like a tibial tubercle transfer, osteotomy, or sometimes even a trochleoplasty, to deepen the groove becomes mandatory to provide lasting stability and prevent devastating further recurrences and cartilage damage. And don't forget the VMO muscle, the vastus medialis obliquus. Its function is crucial too. It provides the dynamic medial pull. If the VMO is significantly damaged or atrophied, or if its insertion angle is abnormal due to malalignment, that also contributes heavily to instability.
Right. So if the MPFL, that passive restraint, the leash is gone, and the VMO, the dynamic medial pull, is shredded or ineffective, the patella is essentially running completely free laterally.
Correct. It has lost both its static and dynamic medial stabilizers. The ultimate goal of surgery, therefore, is always to restore the normal kinematics. We need to ensure that the combination of a stable medial tether, the MPFL reconstruction, and corrected bony alignment from osteotomy or trochleoplasty if needed, allows the VMO to function effectively again, pulling medially and making the patella track safely and reliably within the bony confines of the trochlea throughout the range of motion. It's about restoring the whole system. Hashtag outro.
Wow, this has been a necessarily detailed but incredibly valuable deep dive, really moving us from that generalized anatomy knowledge to truly specific surgical and diagnostic detail that matters for outcomes. We started way back in the posteromedial corner, that subtle, complex, multi-layered stabilizer, and clearly established that its integrity is absolutely essential for dictating the long-term success of any cruciate ligament surgery you might perform. We dissected its layers, we meticulously traced the 5 often confusing dynamic arms of the semimembranosus, and we really detailed the crucial high-stakes role of the POL in preventing that rotational failure pattern known as AMRI, which is just poison for an ACL graft.
Absolutely. And then we transitioned pretty seamlessly, I think, to the anterior powerhouse, the extensor mechanism, focusing specifically on the common acute injury pattern of lateral patellar dislocation. We underscored the absolute necessity of high-resolution MRI to spot those often concealed findings like the critical sliver sign. And we emphasized that the imaging workup isn't truly complete until we also assess those underlying predisposing anatomic factors, the trochlear morphology, the patella height, and that TTTG distance. Because those factors are what ultimately dictate whether we simply repair a torn ligament or if we need to fundamentally realign the entire knee with bony procedures to achieve lasting stability.
The message seems undeniable. Simply repairing a torn structure, whether it's an ACL or an MPFL, is often insufficient if the underlying biomechanics are flawed. Understanding the specific, often overlooked anatomy down to the pars reflexa of the SMT causing magic angle or the critical femoral attachment of the MPFL and applying that knowledge to identifying the biomechanical failure patterns like AMRI or severe patellofemoral maltracking, that's what moves us from simply fixing a tear to truly restoring complex, lasting knee kinematics. As you said, missing the PMC is literally increasing the stress on the ACL graft you just spent hours perfecting. You're setting it up to fail.
And that leads directly, I think, to the final provocative question that really must challenge every orthopedic professional's preoperative planning process today, especially in complex knee injuries. The literature, and certainly our shared clinical experience, is unanimous on this point. The PMC is still often overlooked or underappreciated, and we know biomechanically and clinically that combined PMC and PCL injuries lead to disastrous increases in posterior tibial translation and almost inevitably result in accelerated medial compartment arthritis down the road.
Right.
So given the incredible specificity and anatomical detail we can now routinely achieve on high-resolution MR images, the core challenge for us moving forward is this. How do we effectively translate that unprecedented level of anatomical and pathological detail, that definitive diagnosis of an AMRI risk factor on the MRI, for example, into immediate mandatory surgical steps? How do we ensure that the next generation of ACL and PCL grafts don't become predictable collateral damage simply because we failed to address this tragically forgotten and yet critically important corner of the knee?
It definitely requires a shift in priorities, maybe dusting off those old anatomy texts alongside reading the MRI. A crucial question to ponder. Thank you for joining us for this incredibly insightful deep dive into the stabilizers and powerhouses of the knee.